let's move to the younger patients who are eligible for transplantation. First of all, Professor San Miguel, what is your reaction to the first randomized trial that we had the data in this meeting from Antonio Palumbo, which compared MPR versus high-dose melphalan, and which showed that there is a progression-free survival in favor of early transplant?
If I should confess what was my reaction, I would say that I am happy to see this, because it's what we expected. I think autologous transplant...
Because we consider it as a standard of care.
This is the point. It's something similar to the question about the melphalan. I think it's not good to avoid to exclude treatment that has demonstrated efficacy. I think the best approach is to build up on the efficacy and to continue to improve. Then the transplant, in this case, is associated, I think, with an excellent quality of life for several years in the patients that are transplanted, and the cost, at least in our countries, are now much lower with the transplant.
Yeah, but I would like to add that during the transplant there is, of course, increased toxicity, and if you can avoid this additional toxicity by with, let's say, modern or novel drugs, then I think it would be a big advantage. Progression-free survival, I mean, is clear, significantly better at the time being, but what is important is also to show that this is associated with a better quality of life for those patients, and I'm not sure whether that will be clearly shown. Because you have then not only to measure the quality of life in the first treatment period, but also after later on. And so, and we don't have this data. There's only one trial which has looked at this data, as you know, and well, people looked at quality of life in patients who have received transplant early on as compared to those who have received transplant at the relapse. There was, of course, at the beginning, quality of life was better, but at the end, I think it leveled off because of the subsequent treatment which is then necessary. So I think we have to wait, and also I'm not sure whether that will have an impact on overall survival. But for those people...
But still, we consider transplantation as a standard of care.
At the time being, it's standard.
And Professor Sonneveld, you presented the very interesting HOVON data. So what is your induction treatment of choice that you recommend to European colleagues, and for how many courses?
Well, as I explained, my preferred induction regimen would be a Velcade-based induction regimen, and preferably a triple drug regimen for 3 or 4 cycles, since we and others have shown that with such an approach you can achieve up to 30% of CRs and 60% of very good PRs or better. And then by transplantation this further improves. I also want to remark about the high-dose melphalan and autologous transplant, that there is some toxicity, but it's subacute and acute toxicity during a period of only 2 to 3 weeks. And then most patients improve, and so if you compare transplant-related toxicity with toxicity associated with prolonged treatment over 1 or 2 years, I'm not sure what is to be preferred. And,
in fact, I have the experience with some of the patients that when they relapse, they say, "But is any chance for me to have another transplant?" I mean, there are pros and cons, obviously.
Absolutely. Yes. So, do you still believe, Professor San Miguel, that we need to use an intensive dexamethasone in the induction treatment for younger patients who will be candidates for stem cell collection, or you have reduced to?
I think this is an important question, because in Europe, what we call intensive in the past, dexamethasone, is not the same that was used in the United States. 3 pulses of 4 days was the standard in the United States. Now they have moved to 1 weekly, And we used to have 2 pulses at the maximum. Then probably if you have a young patient, 2 pulses could be something adequate as part of the debulking regime, but not the 3.
If the patient is symptomatic at the beginning, if he's young and if there's no risk for untoward dexamethasone toxicity, probably one can start with the old regimen, but then as soon as the patient improves,
so let's move to a very important question that has emerged the last few months, the role of maintenance with lenalidomide, the potential risk of secondary malignancies. We have just heard extensive presentations regarding these issues. So, Professor Sonneveld, what is your current opinion?
Well, I have an opinion about maintenance therapy, and this relates to the HOVON GMMG trial that we just performed, where bortezomib maintenance was used in one of the randomization arms. So this was a trial that employed bortezomib from induction to maintenance for 2 years. And I think maintenance treatment in that trial contributed to the better progression-free survival and overall survival that we observed with bortezomib. As for lenalidomide, this has been introduced also quite recently by the French group, and other groups have also shown the results in both the elderly and the younger patients. I can talk for half an hour about that, but let's not do that. What we have observed is that lenalidomide gives a tremendous increase in response and progression-free survival. And this is, I think, unprecedented in myeloma history. What we see now is that there are some secondary tumors, secondary primary tumors in the studies, and the incidence varies from study to study. But in all of the studies, without going into detail, the benefit risk is far in favor of the lenalidomide use, both in the older and in the younger patients.
So, Professor Ludwig, let's say you managed to be able to administer lenalidomide maintenance after high-dose therapy in a 50-year-old patient with myeloma who has achieved a complete response. Based on all the data that we have heard, the benefit, some potential cost, for how long you will recommend to this patient to get lenalidomide?
I would like to know the correct answer, because what we know, what we have seen from the data is that maintenance treatment with lenalidomide was given until progression or toxicity.
But this is the data that you have. So.
Yeah, the data, but I think now it's mandatory, particularly with the problem which evolved with the secondary malignancies, to analyze or to test, to evaluate whether shorter periods of maintenance would provide the same benefit in terms of progression.
But until we have those data, what you would recommend?
It's very difficult to give a good an evidence-based recommendation, because the data are all based on continuous lenalidomide maintenance. When I draw an analogy to thalidomide maintenance, I would say thalidomide maintenance has been given for a year, 8 months, 10 months, 12 months, and has provided a significant benefit in terms of progression-free survival. And when you do a meta-analysis also on overall survival, also there are caveats. So the hope is that with shorter exposure to lenalidomide, you may achieve the same improvements, but it's not shown. So at the time being, if somebody wants to be on maintenance, I have to explain him that all the data which have been generated are based on continuous maintenance. So I think that is the situation.
And in addition to that, we should realize that in most European countries, lenalidomide is registered for relapse.
No, I fully agree. I mean, this is why I'm saying for the occasional patient who, theoretically can get it. And we know it's not approved and it's not recommended
for the occasional
outside.
patient, I would say we don't know yet. And let's not change our clinical approach.
It's not a standard treatment.
Absolutely.
That's the issue.
Okay.
And in the relapse trials, there was no increased risk of secondary primary tumors so far. So I feel more safe in the relapse situation outside the context of clinical trials.
Yeah.
Okay, great. So Professor San Miguel, your group has presented an update of an important portion of patients with myeloma, patients with asymptomatic myeloma, and your group was the first to perform a trial, a randomized trial, focusing in patients with so-called high-risk asymptomatic myeloma. Based on your data, I think that you probably still recommend observation outside the clinical trial.
No doubt.
Okay.
And it's the same as the maintenance. I think prudence is very important in medicine. And although the trial is positive and is really encouraging trial, the standard for the smoldering should be to wait until progression. But saying this, I think is now being more and more recognized that within the smoldering myeloma, the asymptomatic patients, there are at least two different populations, if not three. One are the patients that you should not call myeloma, neither a smoldering myeloma. You should call probably NGAS because the risk of progression.
But you cannot identify them at diagnosis.
I think we are now more close to identify these patients. If they have any of the three risk factors, they have a rate of progression of 1%, at least in our hands. By contrast, there is a group that is high risk. In this group of high risk is in the group that we should do the investigation. But this investigation.
Yeah, I think what your study has shown us is that we have to focus specifically on those high risk smoldering myeloma patients, and we have to see them regularly in short intervals in order to capture, let's say, progression as soon as possible.
And to do a more thorough evaluation.
I think that is one of the important messages, and one should speak it out. Yeah.
Probably these are going to be called early myelomas, and the other will change the name in the future.
Yeah.
And that's one reason why, for example, in the new European intergroup trial, these patients will be registered and followed and diagnosed.
Absolutely, that will provide an opportunity to study prospectively in a large cohort of patients. Professor Sonneveld, what is your current definition of high-risk myeloma and of ultra-high-risk myeloma?
Okay.
Based on probably means that most practicing physicians have.
Yeah, so let's first talk about clinical high-risk myeloma, which we have known, of course, for a number of years. Patients with rapidly progressive disease, patients with renal failure due to myeloma, patients with fractures that need to be treated, and patients with deep anemia or hypercalcemia, all those aspects of aggressive myeloma. I would still regard them as aggressive high-risk myeloma at this time. In addition, over the past years, we have got the availability of additional assays like FISH and chromosome analysis, which shows that there are subgroups that are associated with a high risk. And this changes all the time. So if you are asking me what's the current opinion, then I would say there are a number of abnormalities like 70p deletion, the 414 translocation, patients with abnormalities of chromosome 1 that are associated with high risk. But there is let's say, a trend in clinical trials that with some treatments you can overcome or bypass some of the
high-risk to intermediate
of the risk of these high-risk features. And the 414 translocation is one of those that can partly be overcome.
To intermediate.
If I am allowed just to add to this, for me, an ultra-high-risk patient is the one that after an optimized induction and a transplant saw a rapid relapse within the first year.
Yes, but
for me, this is a patient that you don't identify a diagnosis, but for me, this is a patient that should you should do for
You're
him.
absolutely right. I was still discussing diagnostic features.
Okay.
And then I think there will also be a future development, because now, based on gene expression profiling, which is a much more elaborate technique, of course, you can identify and separate high-risk patients from very high-risk patients based on the biology of the disease only. And I foresee that in the coming years, this will be introduced in the clinic.
So, Dr. Ludwig, how you can identify prospectively your patient who has a likelihood to live 2 years or less at diagnosis, with the means that are available to you today?
I think that has already been mentioned more or less. I would of course look at LDH. High LDH is of course an important risk factor. The patient has frequently severe anemia, has frequently...
But I don't think that a renal failure, for example, today, and you have much more experience and you did a great study, I mean, with the bortezomib-based treatment, I mean, is not anymore an adverse prognostic factor.
If you are able to reverse
it, which happens in about 70% of the patients.
But I was talking about anemia, LDH, bone disease, extramedullary disease, and the rare
17P.
17P, and
plasma cell leukemia.
What is important, plasma cell of course, and what is important when it comes to cytogenetic abnormalities, a combination of adverse cytogenetic abnormalities is probably an indicator of very high risk.
If you have 17P, it matters. 14. If you have something
if you have 17P plus 14, 14, then you are really a high-risk case. So if you have 17P plus abnormality and chromosome 1, so the combination of cytogenetic risk factors is probably a very untoward negative prognostic feature.
And the combination of cytogenetic or FISH abnormalities with the ISS, as Dr. Avet has shown.
So Dr.
And just put on top of that extramedullary disease.
Yes. I mentioned extramedullary.
Yeah, no. About just to recapitulate these three features.
Yeah, we talked about plasma cell.
So Dr. Sonneveld, what is your recommended treatment for a patient with ultra-high-risk myeloma? I know that this is a tough question, that we don't have very many trials that have focused in these patients, but what you would recommend to as a consult to a physician who asks you about such a patient?
Well, independent from whether it's just clinical features or
let's say it's a 50-year-old patient who comes with 3,000 plasma cells in the blood and he has a 17P deletion.
That's really unfavorable, yes.
Yes.
So this patient has plasma cell leukemia and 70P deletion, and in fact his myeloma is a genetic disarray. So I would first start treatment fast, the same day, and treat him with a bortezomib-based regimen, triple drug regimen for 3 or 4 cycles, go to a high-dose therapy and autologous transplant regimen, and then proceed, if possible, to an allogeneic transplant as soon as possible after that.